licensed psychiatrist. She is on the CAP line. So some of you may have actually spoken with her at different times with asking like advice on some of your cases. And we also have Dr. Anna Swan, who is a child psychologist and who previously worked with CAP doing like our second step consults, what we used to call second step, now called ROC, Reach Out and Connect consults directly with families. And so very lucky to have both here with us today to share on anxiety. So take it away.
All right, I'm going to proceed to the next slide. So we don't have any financial disclosures today, and we are hoping that you are going to come away with an understanding of how to identify and diagnose anxiety disorders in primary care, an understanding of what are the evidence-based treatment options, both therapy and medication, and with some resources that you can share with families. Next slide. So what is anxiety? This is usually where I start when I'm working with families. And I like to start with anxiety is a human emotion that we all get to experience. And there are kind of three components to anxiety. There's the feelings piece of it. So with anxiety, you're thinking about that fight, flight, or freeze response. Your body is preparing you to deal with a dangerous situation. And so a lot of times you might see this come up in primary care in the form of frequent stomach aches, headaches, muscle tension, trouble sleeping, things like that. Then there's the cognitive component. So usually when we're feeling anxious, we are thinking ahead to bad things that might happen so that we can do some contingency management and be prepared. And so you can see how this is actually a really helpful thing when anxiety is at sort of appropriate levels. And then the third component of it is the behavioral piece. So every emotion kind of comes with a behavioral urge. And when we're thinking about anxiety, this is not a comfortable feeling to have. People generally don't like feeling anxious. And so the action urge is to escape from that situation, get out of it, or to avoid it altogether. And so, like I mentioned, we all get to experience anxiety. And a lot of times it's a really helpful and adaptive feeling to have. So if I'm feeling a little bit of anxiety about an upcoming test, maybe some butterflies in my stomach, I'm thinking, I need to study so I can be prepared and show what I know on the test. And that might motivate me to, get started and to be really focused when I'm taking the actual exam. But it's also easy to imagine how sometimes that kind of adaptive level of anxiety can become so loud or happen so often that it really starts to get in the way. So maybe I'm feeling that anxiety about that test and I'm thinking I'm going to fail, like I have no idea what I'm doing. And so that is such an uncomfortable feeling whenever I think about the test that I procrastinate, I don't study, and then I miss school because I'm feeling so anxious about having to take this test I haven't prepared for. And so that problematic anxiety, I'll often use this example of a broken smoke detector or a false alarm, where that anxiety alarm is going off so often and it's so loud that it starts to hold children and teens back from doing the things that they need to do or that they want to do with their families, in school, and with friends. And so when I'm thinking about kind of, is this typical anxiety that we all get to experience, or has this anxiety become elevated to the degree of meeting criteria for an anxiety disorder? I like to think about the 4 Ds. So the first is dysfunction. Is anxiety keeping the child back from doing what they need to do at school? Are they not participating in class? Are they having a hard time going to school? With friends, are they having a hard time socializing because of anxiety? And or with their families, causing a lot of disruption to the family routines because the anxiety is so intense. I think about distress. So again, anxiety is an uncomfortable emotion. If it's happening a lot and it's happening to a really intense degree, these children and teens are usually pretty in a lot of distress around it. The third one's duration. So it's really common to have elevated anxiety at points of transition. It's like that first month returning back to school. A lot of kids are experiencing elevated anxiety, adjusting to that. But when anxiety is lasting for 3 to 6 months or longer, that's kind of my cue. This level of anxiety is probably not going to just go away on its own. And then the fourth D is deviation from the developmental trajectory. So here you're really thinking about how is this anxiety presenting within the context of the child's development. So super common for a toddler to experience stranger danger and have a really elevated fear response when they're meeting somebody new. But if we're seeing kind of this similar response in a 10-year-old, that suggests that this is a deviation from what we would expect to see in development. Next slide, please. So here are some quick facts about anxiety disorders. They are incredibly common. In fact, they're the most common psychological problem that we see in children and teens. 3 in 10 children will meet criteria for an anxiety disorder by age 18. And this is kind of old data. I think that I expect that we'll see even higher rates of anxiety within the wake of the pandemic. I'm sure you're seeing this in your own primary care setting, and we're certainly seeing it here at UCSF. We also know that a lot of times anxiety disorders are overlooked. Often children who are having elevated interfering anxiety are not causing behavioral problems in the classroom, or not causing a lot of problems at home. And so they just kind of fly under the radar, but internally they're experiencing a lot of distress, and it causes significant impairment in both academic, social, and family functioning. The other thing that we know is that without treatment, anxiety disorders do not tend to just kind of go away on their own. Kind of a watch and wait approach is not appropriate once anxiety has kind of reached the level of meeting criteria for a disorder. And in fact, we see that anxiety tends to persist into adulthood and can even be kind of thought of as like a gateway disorder, where we see that untreated anxiety leads to the development of both other anxiety disorders, depression, and substance use later on in life. So it's really the early identification and treatment is key. A lot of times I'll work with teens who sort of experience that onset of social anxiety in middle school. They had a hard time making friends. They were more isolated. That really set the stage for developing depression in their later teen years, and then potentially even developing a problematic coping in the form of substance use and abuse. So that's why we are all here today, because primary care is such a beautiful way to increase the identification and treatment of anxiety. And there was a recent call from the U.S. Preventive Services Task Force that just came out April 2022, recommending that we start screening for anxiety disorders starting at age 8, just because of the increase in mental health concerns that we've seen in children within the wake of the pandemic. Next slide. So here we have just a general overview of, what are the different types of anxiety disorders that you might encounter within primary care. Quick note, with anxiety, comorbidity is the rule rather than the exception. Most children who meet criteria for one anxiety disorder will probably meet criteria for a different anxiety disorder. And they're also commonly comorbid with other concerns like depression or ADHD. And sometimes we'll kind of see the course of anxiety change over development. So you might see a younger child who has separation anxiety, and then that kind of shifts and becomes more social anxiety during the teenage years. So I'm just going to kind of quickly go through these more common anxiety disorders, so you kind of have an understanding of what to look out for. What are the key features of these different disorders? And I'll start with separation anxiety. So here, the key feature is worry about harm coming to either the child or the loved ones when separated. So these children might have a lot of worries about, I'm going to get kidnapped, or when I'm away from my parents, they're going to get in a car crash, or they're just going to leave and never come back. And this leads to a lot of distress and avoidance at those separation points. So a lot of times you might hear about difficulty separating at bedtime or difficulty separating for school. And you can often see physical symptoms around separation. So it's really common for these kiddos to have a stomach ache or nausea, sometimes even throw up at separation points, have a lot of trouble sleeping without their parents, or have nightmares. And as you might expect, we see this more often in little kids. For generalized anxiety, the key feature here is worry. So that's what I think of when I think about generalized anxiety. These are children and teens who are having daily excessive worries that they get stuck in and they can't control. And sometimes the worry can really be focused on a couple of domains. So it might be worries about school and grades and not making any mistakes, kind of those more perfectionistic worries. It might be worries about performances and like meeting one's own high expectations, worries about the future, things they see on the news, family worries. And then sometimes there might be kind of flavor of the day worries. So the content of the worry changes and shifts, but this child or teen is always worrying about something. And again, we see physical symptoms that come along with the worry. So trouble sleeping, because these worries really kind of tend to come out at night often. Feeling more tired when worried, muscle tension. A lot of times we'll see these kiddos have a lot of irritability when they're worried, or have trouble concentrating and focusing when they're worried. And so here you're thinking about a differential. You want to also be assessing for depression and things like ADHD, and sometimes it can be hard to kind of suss out what's going on. Social anxiety, the key feature here is fear of negative evaluation from other people. So there's that worry. Other people are thinking about me, and chances are they're thinking something negative or bad. I'm going to do something really embarrassing and people are going to laugh at me. And then there tends to be a lot of either white knuckling it, a lot of distress in those social situations, or avoidance of social situations. And there are kind of two main categories of social anxiety. So one is performance situations. So I'm feeling really nervous about giving that class presentation or answering questions, being called on because I might do something embarrassing. Or the second category is these less structured social situations. So a lot of anxiety about, am I going to say the wrong thing? Am I going to get laughed at, like starting a conversation? Am I going to get rejected by a friend if I invite them over? A lot of anxiety and avoidance of parties, having a photo taken, texting, calling, that sort of thing. And so some teens will just have social anxiety in one of those categories, but often it comes up in both. And we see this come online more during the adolescent years, as you would kind of expect. Sort of all teens are starting to care more about what their peers think of them, and then anxiety kind of co-ops that in children who are struggling with social anxiety and causes a lot of distress and interference. The next one on here is panic disorder. So the key feature here is a panic attack that occurs untriggered, kind of out of the blue. So you can experience panic attacks within the context of, say, generalized anxiety, but with panic disorder, at least one of these attacks is happening when the child or teen is not in an anxiety-provoking situation. They're not thinking anxiety-provoking thoughts. This just happens all of a sudden, and it leads to a lot of related distress and worries and interference about something like this happening again. And then the last disorder that I'll just spend a little bit of time on is OCD, or obsessive compulsive disorder. This is technically no longer in the anxiety disorder section of the DSM, but as you hear me describe it, it has a lot of similarities with the other anxiety disorders, and there are a lot of similarities in terms of how we treat OCD. So the key feature of OCD is this child or teen is experiencing intrusive, distressing thoughts or images. So classically, you might sort of the common one people know about is, contamination concerns, intrusive thoughts about dirt or germs. But there's a whole host of the kinds of intrusive thoughts a child or teen might experience. It might be violent imagery, but they're very distressing. And then because that thought is so distressing, then there is an associated compulsion or ritual. And this serves the function to relieve that distress in the moment. So for example, if I'm having a lot of intrusive thoughts around contamination, I might engage in excessive hand washing, and that relieves my anxiety in the moment. Or if I'm having intrusive thoughts about these violent images in my head, I might do a mental ritual. I might need to say a prayer or say some sort of phrase in a particular way to keep that thing from happening that I just had this thought about. And while that compulsion or ritual really relieves the distress in the moment, it actually feeds the OCD over time. So I'll often use this analogy of like a rash, where if you've got the rash, you itch it, that's the compulsion. It feels, you get that relief, but then it kind of spreads the rash, and OCD can really grow. And so it's not uncommon for children and teens to have some kind of intrusive thoughts and maybe some rituals that they're doing to meet criteria for the disorder diagnosis. It needs to be causing meaningful interference. And usually we kind of we have this like hour in mind, like is OCD taking up at least 1 hour of this child or teen's life each day? So that's kind of the quick breeze through what the anxiety disorders might look like. Next slide.
So it can, I think it can be a lot to remember all these different symptoms and types of anxiety. And one of the things that I think is very helpful to help kind of think through the different symptoms that might point towards anxiety disorders, and also think through whether this kid is experiencing kind of a normal amount of anxiety versus an abnormal kind of problematic amount of anxiety, is to use rating scales. So two of the ones we most commonly use are the SCARED and GAD-7. The SCARED has been validated for ages 8 to 18. We do sometimes use it for kids younger than that, but I think that's helpful to keep in mind that it's not validated for those younger kids. So especially some of the questions about like, are you worried about being away from your parent kind of overnight or things like that might not be as appropriate for those ages. The SCARED has both a parent report and a self-report, and assesses for kind of overall anxiety, as well as some of the specific subgroups, including generalized, separation, panic, social, and also school anxiety. The main disadvantage of the SCARED is it's 41 items, so it's a longer form to fill out. And then the GAD-7 is validated for ages 13 plus. It's a self-report. And this one specifically looks at the symptoms of generalized anxiety. And one of the advantages of this one is it's much shorter. So if you've got teens where you're kind of monitoring general anxiety over time, this one's a lot easier to use in terms of tracking. But both of them can be used kind of for getting kind of initial assessment, helping with evaluation for anxiety, as well as for tracking response to treatment over time. And these are they're available free, and you can access them on the CAP website, which is linked there.
Okay, so we've got some good news. We know that anxiety disorders are really common, they're very interfering, and we have very effective treatments for them, both in terms of medication options and therapy options. Next slide. So I'm going to talk a little bit more about sort of the therapy piece of treating anxiety disorders, specifically cognitive behavioral therapy, or CBT, which is the treatment that has the most support behind it for child and teen anxiety disorder treatment. And in a typical course of cognitive behavioral therapy, the child and teen are learning skills to target each of those areas that anxiety tends to impact. So if you remember to our first slide, there are kind of those three pieces of anxiety. To address that physical piece, that kind of like activation in that sympathetic nervous system, the fight, flight, or freeze response. Kids are often learning mindfulness strategies, ways to be mindful and tolerate those emotions. Sometimes we'll also do relaxation strategies to target that cognitive piece, which is the tendency for anxiety to think of the worst case scenario, think that it is incredibly likely to happen, even when it might not be, and think that if it does happen, this child is not going to be able to handle the situation. We'll use cognitive restructuring strategies, which is basically working with the child or teen to help them kind of think about the situation in a different way, where their thoughts are more realistic or more balanced or more helpful. And then the last component is the real magic ingredient to cognitive behavioral therapy for anxiety, which is addressing that behavioral piece of anxiety. So when we're nervous, that's not a fun place to be. So we want to avoid that threat. We want to get out. But unfortunately, that maintains the anxiety over time. And so in CBT for anxiety, we teach some things like problem solving. What are some ways that you can kind of think about the problem, so maybe you can take a stepwise approach to engaging in it rather than avoiding it. We'll teach distress tolerance. So kind of what are some things you can do in the moment to kind of get through that anxious moment. And then the real key ingredient is gradual exposure. So I'm going to share a little bit more about that on the next slide. So we know that there might be a lot of different reasons that a child is experiencing elevated anxiety. And we also know that avoidance is really the main thing that keeps it, that makes it persist over time. So I'm feeling really anxious about saying yes to this invitation to hang out with a friend. And so I avoid it. I get my mom to call my friend and say, you know, we have a family obligation, I can't do it. Automatically, I feel so much better. I don't have to do this thing. I was feeling nervous about being embarrassed or saying something silly. And then unfortunately, that means that I miss out on this opportunity to have a different experience potentially than kind of what anxiety said was going to happen. And I also miss out on the opportunity to develop this friendship. And I also don't have the opportunity to learn that maybe I could handle it. You know, maybe it would even be fun. And so with exposure therapy, we're working with children and teens to help them develop a step-by-step plan where they can practice at their own pace. We're not just throwing them into the deep end of the swimming pool. We are gradually helping them practice staying in those situations when they're feeling nervous so that they can have this coping experience and kind of build up that muscle of being able to do more and more things that they were feeling nervous about. And I'm happy to, at the end, if we have some time, if people are wondering what specifically that might look like, I'm happy to give some examples. Next slide. Parents. Parents are key. Parents play a key role in helping their child to face fears rather than avoid those difficult situations. A lot of times we say in psychology, we have an acronym for everything. So here's another acronym for you. You want to have in mind some kind of top 4 tips to share with parents about what they specifically can be doing to help their child or teen with anxiety. They can care for them. So the C stands for being a coping model. And this is different than being an expert model. So an expert just, you know, breezes through life, no problem. It's really helpful for caregivers to actually do the work themselves and be able to model for their child how to recognize when they themselves are feeling nervous, the anxious thoughts they themselves might be having, and then how to adaptively cope with that anxiety and handle it and practice being in those situations when they feel nervous. And that can be really powerful for children learning how to then do that themselves. The A stands for accommodate less. And this can be kind of confusing because usually when we think about accommodations, we're thinking about 504 plans or IEPs, and it's like a positive, yes, we want to have accommodations in place. In the world of anxiety, accommodation means anything that the environment is doing, the family system or the school system, to help a child avoid or escape a situation when they're feeling nervous. And there's a lot of, although we can all understand why this happens, there's a lot of research that actually accommodating the anxiety makes anxiety worse over time. That being said, if you have a child who's experiencing a lot of anxiety, you can't just, again, throw them into the deep end of the swimming pool. You need to come up with a gradual plan. And so a question that I recommend parents ask themselves or schools ask themselves, is this accommodation supporting my child in, you know, taking a step toward the situation, or is this accommodation helping them escape or avoid the anxiety? So for example, if you have a child who's feeling nervous about presentations and you say, it's fine, just like write an essay instead, then they're missing out on that opportunity to gradually face that fear. A different accommodation might be start with giving the presentation in front of your teacher alone, and then in front of a small group, and then work toward doing it in front of the class. So that is an accommodation, but it's one that's helping them gradually face fears. The R is my favorite, reward brave behavior. It is hard to do things when you're feeling nervous. It is like really, really difficult. And so parents can play a huge role in giving lots of praise and even tangible reinforcers for when their child is doing exposures and being brave. A lot of times, you know, parents are like, oh, is this bribery? So usually what happens is after repeated exposures, the experience becomes naturally reinforcing. So you don't have to keep those tangible rewards in place for forever. But in the beginning, that can be a really helpful motivator to kind of get through that initial anxious avoidance. And then the last piece is empathize and normalize, telling kids not to feel nervous, being frustrated or punitive, not super helpful. And so instead, it's great for parents to be able to show their child they understand why they're feeling nervous, really empathize, normalize. We don't want children to feel anxiety about their anxiety. You want to normalize and make them feel understand that lots of people feel this way, that it's a safe feeling to have, and that anxiety is a temporary feeling to have. It, even if you do nothing, it will kind of go away on its own. Next slide.
So that gives you a sense of some of the behavioral interventions that can be helpful for anxiety. And then we also wanted to talk about kind of when it's time to think about medication. So there's some different situations that it can be helpful to think about medication for treatment of anxiety. One is if they've been doing therapy and having limited improvement with therapy, if their anxiety is especially severe, so having like a GAD-7 over 16. If the anxiety is so intense that the patient is unable to engage in those exposures that Dr. Swan was talking about. And also times if there's a comorbid disorder that also is requiring treatment. So for instance, if they're dealing with both anxiety and depression. And I think an important thing to keep in mind is while in randomized controlled trials, either CBT treatment or SSRI treatment significantly improve anxiety symptoms compared to placebo, the combination of CBT and SSRIs is the most effective, powerful treatment and has shows more benefits compared to either one alone. Next slide. So in terms of medications for anxiety, the SSRIs are first line. These are three of the ones we use most commonly: sertraline, fluoxetine, and escitalopram. There's no empirical evidence that a particular SSRI is more effective than another for treatment of childhood anxiety disorders. Clinically, we kind of generally make the choice based on side effect profile, duration of action, or if a family member has had a particularly good or bad response to an SSRI as well. In the chart, you can see kind of starting doses, the titration increment, and then typical dose range. For kids, we recommend starting at low doses and then kind of gradually going up, monitoring kind of both the benefit and side effects, and kind of increasing based on their response and tolerability. And I think one thing that's kind of helpful to keep in mind is for, all of these are actually off-label for anxiety disorders. You see sertraline has an FDA approval for OCD, ages 6 and up. Fluoxetine has approval for MDD and OCD, ages 7, 8 respectively, and escitalopram is approved for MDD, ages 12 and up. We do all use these in anxiety disorders very commonly. And kind of we tend to use sertraline and fluoxetine, especially for those under 12, escitalopram, kind of, and the other two all in teenagers. So those are some general principles. And then in the next slide, we've also got some additional resources that can be helpful for families. I really strongly recommend these. I think somebody commented in the chat that, when is it parent anxiety, when is it child anxiety? And we do so often when we see an anxious child, there's also an anxious parent involved. And so I find these books can be really helpful for both anxious kids and their anxious parents. And it really talks through a lot of those strategies that Dr. Swan was talking about. And often, not for the severe, but more for the mild range. And also maybe for kids that have some anxiety that, if they keep avoiding, it's going to get worse and become a disorder. But if they kind of if the parent and child learn how to do some brave exposures on their own, might not even make it to the point of being a full disorder. These can be very helpful. And if you go to the CAP website, you can see more of these resources.
Thanks so much for the great talk. I don't know, there are a bunch of great questions that are here in the chat. I don't know that we necessarily have time right now to get into them all, but one quick one is like if any of these resources are available in different languages that you know of.
I don't know off the top of my head, but I'm happy to do a quick search and get back to the group.
And there were also some questions around screening tools, like when it's okay to use a GAT7, when you shouldn't, and the difficulty in using a long screen like the SCARED in a primary care setting, especially when there are literacy or language barriers. I don't know if either of you have quick thoughts as to, like the utility, like what you would use in screening when you've got a younger kid.
For younger children, there's a measure called the Spence Preschool Anxiety Scale. That's maybe 9 items that I'll use. It's a parent report measure. And then even though those measures are intended to be self-report, sometimes I'll just ask the questions, and I find that really helpful, just kind of asking some of those initial questions myself.
Fantastic. Thanks so much.